Guys. I hope Mason and Dalton are here. It's their favorite subject. So we're going to talk about constipation today. Um, we'll go over basic differential, and please feel free to interrupt me and chat with me and ask questions because you know that's how I like to do lectures anyway. So it starts with the typical case. 4-year-old female presenting with painful and frequent BMs, about 3 times a week, without blood, occasional stool leakage into underwear, decreased appetite, no organic symptoms. What do you think? Heather, did I hear you? Anybody? Okay, well, I would call it encopresis because there's a stool leakage, right? So constipation with stool leakage is gonna be encopresis. So objective for the lectures today will be know the differential diagnosis for constipation, differentiate functional versus organic, understand the pathophysiology, and try to learn about the treatment, right? It gives you flexibility. Not everything is treated with Miralax. We know that, right? So just tell you how busy I am with constipation. It's 3 million Americans receive medication for constipation from their physician. 3% of general visits to general pediatricians and about quarter visits to me. Like today it was 100% constipation visits in the morning for me. So I feel very blessed. So definition is a term used to describe the subjective complaint of passage of abnormally delayed or infrequent passage of dry, hardened feces. Remember, it's subjective, right? Not objective. So hard stools, large stools, infrequent stools, or discomfort with passage of the stools. So in infants, depends whether the babies are full food for formula fed or breast milk fed. With the breastfeeding babies, remember every time they breastfeed, they poop, and stools are usually yellow seedy consistency with no smell. For the formula babies, they stool a little less frequently, maybe 3 to 4 times a day, maybe less. The stools are a little more foul smelling and a little darker color. Children's up to 2 years of age will poop up to 2 days a day, 2 times a day. And adults, 3 per week for 3 per day. I would say on average, you expect one bowel movement a day. Bristol scale 3 to 4. You don't want to have less frequent or more frequent stools. So red flags on history and physical examination will be constitutional symptoms like fever, anorexia, weight loss, vomiting, bloody diarrhea. On physical exam, if you have perianal tags, fistulas, anal abnormal anal tone, absence of anal wing and sacral tuft of hair. So remember, guys, the normal position of skin tags, you can have skin tags with constipation. So the normal position of skin tags or fissures will be either 6 or 12 o'clock. Anything that is not 6 or 12 considered to be abnormal and should make you think about inflammatory bowel disease, not hemorrhoids. Okay, it's unusual to have hemorrhoids in the pediatric population. So that's your differential diagnosis, organic versus non-organic. So developmental like infant dyschezia, cognitive, ADD patients, situational, kids are afraid of using the toilet, are not properly toilet trained, dirty bathrooms in school, sexual abuse, constitutional, like genetic predisposition. If the family has history of constipation, a lot of kids will have constipation as well. Reduced stool volume and dryness is going to be either too much fiber or too low fiber, not always low fiber, right? If you have somebody A lot of vegans will be constipated because their amount of fiber is actually way too high, but they don't get enough water. So rough rule of thumb for fiber supplementation is 5 grams plus age. Anybody who tried to do 30 grams of fiber in adulthood understand how hard it is. But in pediatric population, 5 grams per age is something that you can, plus age, can manage. But remember, every time you recommend fiber, you should recommend water as well. Okay, you can't just do fiber without water. That goes for tube feeds as well. And then if the child doesn't get enough calories, malnourished, they might be constipated as well. Now, organic reasons for constipation would be anatomical abnormalities like anal stenosis or anteriorly displaced anus, spinal cord lesions like tumors or tethered cord, neuropathic lesions, right? Again, the tumors, metabolic conditions, thyroid comes to mind, right? As well as celiac disease, systemic disorders, lupus will do that, IBD will do that. Drugs, mostly pain medications, as we know, but there's some other medications that can do that. Um, are you all with me? Yeah, you guys okay? I don't see you. You put the cameras down too, so I don't even see you nodding except one person. Hard to function without interaction, guys. I'm trying. I'm trying. All right, let's talk about organic causes of constipation at least. Oh, thank you guys. And then Megan switched it off and ran away. All right. So let's talk about organic causes. So chronic intestinal food obstruction, first on the list, is very rare, believe it or not. So it doesn't usually appear early in life. It actually gets worse over time. So the kids can be actually pretty healthy with an age, and then getting progressively more distended, constipated, gaseous, distension. The difference is going to be with food obstruction. They're actually going to see a lot of gaseous distension more than the full of stool patients. They're not really that constipated per se. They just cannot evacuate. Anal stenosis just so happens so a kid today with anal stenosis. Again, very bloated bellies, they very easy to diagnose if you put the Q-tip in, and you can really do that. That's a neonatal diagnosis, and Q-tip is very small and soft. And if you have trouble putting the Q-tip in, that kid is probably stenotic. Anal colonic stricture in the NICU babies or IBD patients from neck. Ectopic anus, mostly interior, it's not even ectopic, more than anteriorly displaced. So again, the rule of thumb, your anus on a rectal exam, on an external rectal exam, should be posterior third of the distance between the sacral joint and the vaginal or urethral opening, right? If your anal opening is anterior to the third posterior part, I can't even speak anymore, that is anteriorly displaced anus. Okay, so that's the easiest anorectal malformation to correct because there's no proximal abnormalities. That's just that abnormality, just anus. And obviously there's other anorectal anomalies that requires more intervention, but those are more obvious right at birth. Again, spinal cord lesions, we have spina bifida patients, tethered cord tumors, rhabdos are common. Hirschsprung disease considered to be neuropathic lesion. So you guys see a lot of rule out Hirschsprung patients. Obviously, you know, with lack of ganglion cells, and you can have barium enema's in good hands are diagnostic, but usually you need to do biopsy to look for ganglion cells. Intestinal neuronal dysplasia is exact opposite of Hirschsprung. You have too many ganglion cells. And you have those things called interstitial cells of Cajal. You probably don't remember it from histopathology, but It's just abnormal connection between ganglion cells. So you have a lot of cells that don't talk to each other. So the patients act like Hirschsprung disease, but it's exact opposite from histological point of view. Again, metabolic, you'll have thyroid issues, hyperkalemia, PTH, tumors, hypokalemia, uremia also will do that. Systemic disorders. Remember, celiac disease is a great mimicker. You don't have to have diarrhea, you can have constipation. Cystic fibrosis, obviously, if the patient doesn't have enough enzymes, the stools are going to be fatty and bulky, so they're going to be constipated. You see plenty of DOs. Diabetes, I won't say that I see a lot of patients with DM that are constipated unless they also nutritionally mismanaged and eat crap. Again, panhypopit, that also involves endocrinology, scleroderma, dermatomyositis. It's more adult issue. Kids usually don't get that. It's a progressive disease. So is autoimmune disorders. Lead toxicity, I don't see it as much. You guys in pediatric population see more of that. They have to be really severely lead toxic to get constipation. Drugs, the drugs. Iron, I would point out iron just because depends on what kind of salt you use, right? Not every iron salt is the same constipation. So like iron oxidase or sulfate will be more constipated. That's something that is gluconated. So I typically, if I have to put somebody on iron, I will do the gluconate preparation. They used to have this thing called Nithrex. I don't know whether they have it or not, but I typically use that if I need to for kids who are on iron, wants to taste a little better. Antacids, calcium-containing antacid is Milacon and Mylinda and Tums and things like that. So I don't usually use it as much as to cause constipation. Okay, are you guys with me still? Oh, look, Mason, you're here. I'm so proud of you. We're talking about your favorite thing, Mason. So what kind of a workup you're gonna have? So in ideal world, besides history and physical exam, you should do those tests, right? Calcium, thyroid, celiac, lead, CBC. The problem is that, believe it or not, if I put constipation as a diagnosis, insurance is not going to pay for thyroid test, which I think is totally ridiculous. But the reality is, you have to keep those things in mind. I don't know why people make those decisions, but that's a pretty basic workup and it will give you a lot of good answers. Imaging, KUB is enough. Manometry, we'll talk about it a little more. So imaging study, right? So when you do the KUB for the patients who are for constipation, make sure that you actually get the rectal area. As you can see here, you can see big rectal dilation with the stool in the vault, right? So might have a normal stool, normal area above, but the rectal vault will be full. Unprepped barium enema to rule out Hirschsprung disease, full transition zone. And then there's a study called SITS marker study. We've been kind of going in and out of the favors right now. I haven't really done a lot of them, but we can. It's a capsule with markers that you do follow-up films on, and depending on distribution, you can see how long it takes for that. So if you see it scattered through, was there a question? No. If you see the scattered through markers, that may be colonic inertia versus outlet dysfunction when they sit right there at the rectum, but they cannot get evacuated. So anorectal manometry is something that we provide in our office. So you can actually do the manometry study to help you to decide what's the next step is going to be for patients therapy. This is a little more advanced than just medical therapy. So if you fail the medical therapy, that's what you do next. So you can see if the patient has increased rectal sensation, whether there's a paradoxical contraction, whether there's a failure of relaxation. Based on these data points, the next step will go to special physical therapy people who do so-called biofeedback therapy. and those patients can respond to certain exercises, and depending on the findings that on anorectal manometry, the exercise are going to be tailored to it, whether it's going to be relaxation techniques or retraining the muscle coordination. And we actually have that too. We can do biofeedback to our patients. um, Anal sphincter myography also can be evaluated. This is something that we don't do as much except on the very little babies. It's very useful for postpartum women to evaluate how dysfunctional the anal sphincter is postpartum. Pelvic floor dysfunction is something that every woman that delivered the baby will suffer, so urogynecologists will use that a lot. Rectal biopsy for Hirschsprung disease or IND, and you see that a lot on the ward will do that pretty frequently. But this is how manometry looks for the babies with Hirschsprung disease. If you follow me along, you see that there's a balloon that sits in the rectum and it gets inflated. And for the babies, that's just enough. You don't really need to do more. You don't need cooperation for that part of the study, so you can do it in the small babies as well. And so you can have normal contraction of the rectum. With Hirschsprung, you see it's going to be a little more pronounced. But if you have external sphincter, you're supposed to have internal sphincter relaxation together with external sphincter contraction. And as you can see on Hirschsprung disease, you don't get that at all. So if you have in the good hands with anorectal manometry, you can actually diagnose Hirschsprung disease without doing liver biopsy. This is pathognomic findings. So let's say you did all the things and it's not organic disease, all the labs are normal, manometry is normal, so then you think it's functional constipation. Okay. So this is a Rome 3 criteria for functional constipation. Right now it's actually Rome 4, so they just got updated, but from perspective of constipation, there is no change. So it must include two or more of the following in a child with development age at least 4 years, right? There's also a neonatal definition of constipation, but pediatric gastroenterologists try not to diagnose them until they're at least 4 years of age. As you can see, two or fewer defecation in toilet per week, at least one episode of encoparesis per week, history of retention or excessive volitional stool retention, painful hard bowel movements, large fecal mass in the rectum, and large stools in the toilet. Okay. So this is how you're supposed to evacuate the stool. And each part of this diagram shows you that you can have abnormalities in each part of it. So for example, if I mentioned before, anteriorly displaced sphincter will affect that rectal angle, as you can see. So angle between the rectal axis and anal canal axis has to be about 90 degrees. So if with anteriorly displayed anus, you're not going to have that. So that will prevent your defecation, okay? Is the patient holding in because the muscles and the sphincters are too tight, right? Or there's the pubertal muscles that are too weak. So all of those things can be evaluated and be defected, and depending on where the deficit is, the biofeedback therapy or surgical therapy or medication therapy will be focused on. So you can have decrease in propulsive force, you can have impaired rectal sensation, you can have functional outlet obstruction, and you also have behavior. So it is a vicious cycle, right? No matter where you start, you're going to end up with four of them all together. And so you can address it also no matter where. You can start any way you want to address it as long as you can be successful at the end. So what are the triggers? The triggers are typically Diet change, my favorite, milk is white poison, right? So you change from formula to milk, your load goes way higher, right? Your casein load more than whey. And that not even the cow's milk protein allergy per se, but there's just change of casein load may be too much for the patients. Toilet training in toddlers, right? So I never push toilet training. I expect that to happen naturally. Nobody gets married in the diapers. So eventually it's going to happen. The problem is that a lot of daycares are required patients be toilet trained. So that forces the family to try to toilet train the kids early than they're ready. So that kind of starts having that issue overall. But if you have a luxury of waiting, I usually suggest for the families to wait. And then in schools, so I don't know where anybody went to school bathrooms, but I don't know anybody who enjoys that trip. So the kids, I usually try to avoid the bathrooms, and eventually withholding behavior causes more constipation. So encopresis, Bissell, is not really a disease. It's just overall overflow with patients who have constipation, right? With organic pathology, patients are different, right? With organic pathology, there's no hard stool in the vault. They just leak non-intentionally. And there's a huge conflict in the family when you have encopresis. One thing that I find that is very interesting to me is that the biggest conflict between the parent and the child with encopresis is the parent don't understand why child doesn't care. Child walks around with the smelly underwear. You can walk in the room and you smell the stool and they don't care. I think there's some mental block that those kids have, because I find it is the most challenging thing with those kids is to actually get them to cooperate. The parents will cooperate and do the clean outs and things like that, but it's really hard for the patients to respond. I don't know what it is about the kids with encopresis, but they just kind of live with it. There's no mental stimulus to say, "Oh, I'm embarrassed. It smells more horrible. I'm not going to do it." It's, I think that's one of the challenging part of treating encopresis. Now, the most common condition in organic etiologies, we can talk about this a lot, is Hirschsprung disease, right? So this is your barium enema, as you can see. This is your transition zone. Remember, the dilated colon is the normal one, right? It's the narrow part of the colon which is not normal, okay? So that's your transition zone. If you're a young kid, you'll see that. But in the kids with a short segment, when they're kind of sort of plugging alone, you're actually not going to see the transition zone. So if you have a high suspicion, you need a good surgeon that will go very, very distally and do the biopsy for ganglion cells. Okay? It's pretty common, right? 1 in 5,000, mostly in males. Any chromosomal anomalies is going to increase the risk of Hirschsprung, Downs specifically, but also Vater association or Charge syndromes. Those are the patients who are going to have Hirschsprung disease as well. Severe enterocolitis is not as usual anymore. We tend to jump on those patients pretty quickly. Um, Fecal impaction is almost unheard of in the patients who are young with encopresis. And then rectal exam is very important, right? So I used to always say to my family that don't do rectal exam or rectal stimulation for at least 72 hours before you do barium enema, because then you decompress the colon by doing rectal exam and then it's useless. Marcus seems to think that it's not an issue. I'm kind of old fashioned. I still would ask the parents or the nurses on the floor if the patient is admitted not to do it for at least 72 hours before doing barium enema. Okay. So that's the Hirschsprung. We see it all the time. So I'm going to mention it specifically. Now let's talk about therapies, right? The choices you have. All right. See how many choices you have. See how much you can do before you give Miralax or after you give Miralax, right? So most common ones are going to be asthmatic, lactulose, sorbitol. I don't almost never use it, but I will use lactulose. I will use magnesium, milk of magnesia, magnesium citrate. I will use my Miralax, but I'm not big fan unless the patients who walk in the door for me say it's working for them. If they say it does work, then I will continue. But most of the time, by the time they come to me, Miralax doesn't work and I have to do something else. Um, Trouble with all of those medications is that you really need to be brave and give them more than you think you give. You know, what do I always say? You cannot be half pregnant, right? So if it doesn't work, give more. Just because you gave textbook dose and it doesn't work doesn't mean this medicine doesn't work. It just means you have to give more medicine, right? And it works pretty much for everything with constipation. So you start with certain dose that's comfortable for you, for example, for lactulose, and then if 5 milliliters don't work, you go to 15, and if 15 doesn't work, you go to 30. You go to the dose that work for the patient, and then you stay on this dose for a certain period of time, and then you go back, because the minute you decompress the colon, they'll need less. So I will usually start in babies. If I need to do something, I'll do milk of magnesia, and my average range will be 5 to 15 milliliters daily. Um, Magnesium citrate tastes disgusting, so I'll use it for the preps. I don't usually use it as a maintenance. Lactulose is okay, as I said. The both lactulose and sorbitol has a very wide therapeutic range, so you're not going to overdose on them at all. So do what works. I like it much more than mineral oil. I almost never use mineral oil and the kids, especially small one, because of risk of aspiration pneumonia. If you're really old fashioned and you have grandmother Cara syrup, it's pretty much the same as lactulose, so you can do that. It just has to be dark because you need high concentration of sugar. And then the stimulus, senna, bisacodyl, or Dulcolax. Um, I use a lot of Dulcolax suppositoriums, especially for encophoritic patients. I don't find it very helpful as oral medication, but I do love senna, as you know, and we really don't have senna anymore on the market. What we have is called sinusoids, so they don't give you this melanosis coli as much. Again, senna has a really wide therapeutic range, so you give as much as it works, and then you back off. So I think the message that I'm trying to relate to you is that in general, for any medications, just because you pick the dose doesn't mean if that dose doesn't work, you have to change to another medication. You need to try the dose especially if you're comfortable with the drug, you can push the dose high to the effect before you give up on this medication. Because a lot of times I'll see the patient saying, oh, doctor, try this and try this. And when you find out the dose, you really didn't try anything. You just did homeopathic dose and dumped them on me because I have nothing else to do but treat constipation for you, general pediatricians. Right?
Right. Hey, Dr. R.
Yes.
Are any of these contraindicated in someone with IBD that has like a constipation pattern to it, like irritating or
No.
increases perf or anything like that?
No. Not November.
Thank you.
All right, so if you have, the other thing is, again, and this is, you hear me talk a lot about, is that constipation is a plumbing issue, right? So anybody who has a sink in the home knows that you can have an issue in the sink, or you can have an issue in the plumbing down the street, or you can have it at the well, right? So if you have an issue at the sink, it's fine, but what if your issue is at the bottom of the well and you're trying to treat the sink? It's not going to make it any better. So the therapy has to be focused on the whole GI tract, not only on one piece of a tract. So even though you treating them from above, you also have to decompress them, right? So disinfection is very important. Whatever therapy you're going to use, you can't judge the efficacy of the therapy unless the colon is empty, right? So however you get to the empty colon first, and then you start maintenance therapy. So obviously, in this hospital, we've seen a lot of bad constipation, and sometimes we need rectal disimpaction and manual disimpaction and all the good stuff. But on outpatient basis, you come up with whatever works for you is a clean out regimen. I do a lot of Miralax based regimens for kids, and I just dose it depends on age. So like if I have a little baby, for example, 4 or 5 years old, I might stay with 4 glasses of Miralax. But if I have a 16 years old 300 pounder, I might put them on 12 glasses of Miralax. And it's two step forward, one step backwards, right? Just because you disinfected him once doesn't mean that you don't need to disinfect them again. So sometimes if I have really bad encoporetics, I'll put them on some kind of a regimen, maybe like every weekend for 3 months they're going to do clean outs, and then if they do better, I'll space out the clean outs for every 2 or 3 weeks, maybe every month. And I tell the family it's not once and done, it's going to take a minute. And so that keeps the rectum empty, that keeps the colon empty, and then your daily regimen is going to be more efficient versus if you just clean them up once and then they just back up again and you have the same issue again. So don't be afraid to repeat the clean outs on your kids. For the maintenance therapy, just increasing water is not going to make a difference, right? Drink a lot of water is not a recommendation. Drink a lot of water is a cop out, right? So you need combination of water and fiber, and it has to be proportionate. So in general, what I say is everything white is bad for you, everything brown is good for you, right? So that makes them think about dietary choices that has fiber in it. Vegetables that have vegetables have fiber. Any vegetable pretty much is going to be not white except potato, right? So fruits are going to be pretty much all not white except banana and apple. So this way you're giving them choices that are much healthier and easier to pick. And then you don't have to count the grams of fiber because nobody knows how to count anymore. Behavior modification, toilet sitting. Knees have to be above the belly button, right? Humans are the only animals that do not squat anymore when they poop, right? If you look around the world, all the animals squat, and there's a reason for it. That's how you straighten your rectal canal for evacuation. So make sure that the kids have step stool if they sit on adult toilet. Squatty potty is a great thing. Squatty potty commercial, even the funniest thing I ever seen. I still see it if I'm in a bad mood. Unicorns pooping rainbows, great idea for everybody. So they have to be no punishment, reward system, right? If he does well or she does well, that's great. If they don't do well, you just move on to the next task. Psychology referral would be great if you had a psychologist, but this is not something that we have available, so I don't even bring it up really. Because there are some psychologists trained to do toilet training and they come to your house and they'll work with the baby, but that's a she choices that we don't have here in this area. And again, I use laxatives. I do not use stool softeners on somebody who is constipated enough to come to my office. Okay. Now, what if you tried and do everything right and you still cannot get anything done, right? So that's why you see the patients on the floor with cecostomy tubes, appendicostomy tubes. And the reason for that is anterograde enemas, right? If you can't flush from above, you can't flush from below, but you still go forward, right? So that's depending on location of that tube, it's going to be either tube in appendix or a tube in the cecum, right? So that's why it's called cecostomies or appendicostomies. So that helps to keep the rectum empty and the colon empty and retrain them. Sometimes they're so bad that you do need to remove the colon, and we've seen those before, right? And that would be when you have such a big dilation, that there's no propagation of signal, right? So there's nerve connections that are just so spread out that you can't get the signal throwing, and that is a useless colon. So partial colectomy sometimes needs to be done. Diverting stomas might help if you think that eventually the colon can shrink. So you rest the colon and then put it back together. It's not really pediatric choice for like a lot of times the diverting stomas will be done for elderly patients in the nursing homes. I had a couple of patients that needed that done on temporary basis when they had partial colectomy, and then they will put them together. But that's pretty much basics of constipation for you guys. Any questions? Really? No questions. I'm gonna cry. No? All right
All right,
then.
I have a question.
Okay.
So when you were talking about the initial lab workup with calcium and TSH, I mean, at what point do you recommend like just outpatient PCP getting those like right off the bat when the kid's starting to have like legitimate constipation issues, or after they've like failed a couple trials of intervention?
I think after they fail a couple of trials, or if you have alarm signs, if there's a family history of autoimmune disease, like for example, if your mom has celiac, I would check the kid for thyroid for sure, because there's this autoimmune cluster. But if you have no suspicion of organic family history of anything, I probably give a good trial of medications first. And if they fail, then I'll do the medication lab work.
I have another question.
Of course.
So you said, I know you're saying we need to like be brave and commit and just keep going up until it works. But at what point are you like, is it too much and unsafe?
Oh, I have faith you will never go too much, guys. You're chickens.
Okay.
But I mean, I guess it depends on the experience too, right? You eventually gonna get there. So like I can tell you that I for the even for newborns, sometimes if the kids are very constipated, I will do 2 ounces of milk of magnesia on like 4 kilo baby. Like for you, it will be, oh my God, I'm just gonna die right now. But I will do it because they're gonna poop it out. Right. So it's not like it's gonna stay in the system. So but I usually double recommendations, right? If your recommendation is 1 square of X-lax a day for that age, I will start with 2. So I always go a little more than the recommendations are.
Thank you.
Okay. All right, guys. Bye.
Wait, we have another question.
How how do you decide which type of enema to give?
So that's another, it's actually a really good question. I never do pediatric.
My question.
Aw. Aw.
I just didn't want to ask 3 in a row.
So I never do pediatric enemas. Have you ever given enemas, guys?
I mean, not personally, but I've ordered them.
Have you ever seen the enemas?
Yeah.
Okay, so first of all, you always have to see those things to decide. But in general, it's a very soft bottle with a plastic stick, right? And so you put it in the rectum and then you squeeze. And so imagine doing the enema for 5-year-old, and you like he's wiggling or she's wiggling, 5 people holding the baby because something is in their butt and they're like all over the place. So pediatric enemas volume wise is completely useless. There's like nothing there. And so when you have already fighting the child and you try to squeeze it, there's nothing going to get there. So that's why I always recommend adult enemas, because from practical point of view, the fleets, you're not going to get everything in, right? Anyway, so like if you have it in your hand, like the adult enema is like 2 ounces. So if you have it in your hand and you squeeze it, you can get something in versus you have pediatric enema, you're gonna get the squirt, right? So from outpatient perspective, I usually do adult fleet enemas. Now, from inpatient perspective, if you're ordering the enemas for constipation kids and they're like DOS patients and things like that, I usually do like, you guys do gastrography and enemas pretty much on all of them, and I think it's a really good idea. But if you cannot do that, soap suds are really good. And then for CF patients, mucomist enemas are the best. And so I use a lot of mucomist for DOS patients from above and below.
Thank you.
Thanks, Dr. R.
I can't believe Mason has no questions. He's a constipation.
I think he typed some comments.
I don't see it.
He
Where-
said, do we have someone that does pelvic floor dysfunction?
Say it again.
He said, don't we have someone that does pelvic floor dysfunction? And
Yes.
then
Yes, we
someone asked
do.
if Tomlin does.
Yes, we have pelvic floor dysfunction. The person who does biofeedback, that's the one who does pelvic floor dysfunction. Her name is Colleen Rogers, and we've been working with her. We would do an rectal manometry and then send her the patients. So she's doing a lot of our biofeedbacks and pelvic floor dysfunction. How come I don't see it? It's frustrating. Any other chats?
Yes, Mason says, I did a constipation lecture for chalk and I had a lot of this stuff on there.
Mason, do you see the sign on the left says Naspagan? Do you see who did that lecture? Chalk. Look. That's from CHOP. That's where everything happens. Or they think it's where it happens. I can't believe I cannot see this. This is really annoying. Any other chat questions that I'm missing because I don't see it?
No.
No. All right, guys.
Thank
Enjoy
you.
the rest of your lecture time. See you next week.
Bye.
Here I see you.